And we can go ahead and get started. I think that a few people will be joining us, but I'll click them in as they come. So good morning, everybody. This is our third to last action period call. So we're getting toward the end of the project. Kind of a similar structure today from the ones in the past. We'll start with some discussion from the Department of Health about newborn screening. I'm sure they're open to questions as well afterward. We do have our latest look at data for the program, and then I'll go over some of the next steps for everything. Just one little note from me is that I think I have most of the PDSAs except for a few that are missing. That would be the third PDSA cycle. So if you haven't emailed that to me, if you could send that to me, that would be helpful. But I think I do have all of the data for February in at this point. So when we're discussing the data today, it's a full look at everyone's data. Then without further ado, I will turn it over to the Department of Health, and if you don't mind introducing yourself as you come on screen, and I'll click the presentation for you. Here we go.
Good afternoon, everyone. Thank you so much for having us today. My name is Katie List, and I am a program administrator at the Ohio Department of Health. And I'm going to start with an overview of the Critical Congenital Heart Disease Newborn Screening Program. Next slide, thank you. So I'd like to start with a little background. Heart defects are the most common type of birth defect, and they occur in nearly 1% of births each year in the United States. Critical congenital heart defects, or CCHD, are a group of heart conditions that are present at birth and can be life-threatening and require intervention in the first year of life. And about 1 in 4 babies in the US with a heart defect has a critical congenital heart defect. These are conditions that are not always detected in the prenatal period by ultrasound or by a physical exam following delivery. So a baby may look and act healthy after birth and not show symptoms immediately. And babies that are discharged without a diagnosis may have serious problems, and death may even occur within the first few days or weeks of life. Next slide, please. Thank you. To improve early detection of CCHD, screening using pulse oximetry was added to the recommended uniform screening panel in 2011, and then Ohio implemented the screening in 2014. The Ohio Revised Code and the Ohio Administrative Code guide the program, and screening protocols for the program can be found in the Ohio Administrative Code. Next slide, please. The screening program is a partnership between the Ohio Department of Health and Ohio hospitals and birth centers, and it ensures that all babies are screened prior to discharge, and then those that fail receive timely and appropriate medical intervention. So hospitals perform the screening, report the results, either in the Ohio Vital Statistics birth record system or using an electronic form. And then the Ohio Department of Health monitors the reporting to ensure there's consistency of protocols across the state and to provide technical support when needed. Next slide, please. There are some exceptions to screening. Babies with a known diagnosis of CCHD, home births, unless, of course, the newborn's immediately transferred into a hospital for post-delivery care. Those babies who have parents that object to the screening because it conflicts with their religious tenets and practices. And then also any baby that would receive a pediatric echocardiogram in lieu of screening. Next slide, please. So pulse oximetry, it's a quick, painless, non-invasive point of care screening. It's done by placing a sensor on the right hand and one on the foot. It's performed at or after 24 hours of life or shortly before discharge if the baby is going to be discharged sooner. And the baby should be awake, alert, and breathing room air. Next slide. Hospital-grade pulse oximeters designed for neonates should be used and consent obtained from parents prior to screening. Because the screening should be done when the baby's breathing room air, an echocardiogram would be warranted for those babies being discharged home on oxygen. And again, the screening is designed to screen for critical congenital heart defects, not all congenital heart defects, and it's been shown to be successful in identifying asymptomatic newborns with CCHD. Next slide. The sensitivity rate of the screening is currently 50 to 76%. So a critical congenital heart defect should not be ruled out based on the results of the screening alone. Pulse oximetry in conjunction with prenatal ultrasound, physical exam after delivery, and in some cases, genetic testing plays an important role in identifying babies that have CCHD. Babies with a positive screening result would require diagnostic follow-up prior to being discharged home. So if a baby is asymptomatic and otherwise well with no hypoxemia, a cardiologist or neonatologist should be consulted and an echocardiogram performed. And then babies with signs and symptoms of CCHD should have a prompt evaluation, which could even include like an urgent transfer to a higher level of care. Next slide, please. Because babies discharged with unrecognized CCHD may become symptomatic within the first 2 weeks of life, the Ohio Department of Health does encourage facilities to have a plan in place to contact families and the primary care physician if the newborn is discharged home without being screened. Screening can be performed in the primary care office, and it should be considered on the first visit for those babies who were not screened at the hospital. However, if this is done, there should be a plan for further evaluation of infants who either immediately fail the screening or need a repeat screening. And of course, all parents should be educated on the early signs of CCHD. Next slide, please. And this is just a list of those signs: loss of healthy skin color, bluish tint to the lips, skin, fingernails, fast and troubled breathing, shortness of breath, tiring easily while feeding, sweating around the head, especially during feeding, and swelling and puffiness in the face, hands, feet, legs, and around the eyes. Next slide. This is just a few resources for parents. The Baby's First Test website has a video CCHD screening for parents that comes in several languages. The Ohio Department of Health brochure, Understanding Your Baby's Newborn Screening Test, comes in 11 languages. The AAP has a flyer answering, why does my baby need a newborn screen? And then just recently, the AAP website did add a downloadable CCHD fact sheet for parents and also for primary care pediatricians. Next slide. This is a list of national organizations listed that provide support, education, resources, and networking opportunities to families that are affected by congenital heart defects. Next slide. And then some resources for providers. The CDC and the AAP have created a toolkit that helps physicians promote lifelong congenital cardiac care. The AAP website has answers and resources for primary care pediatricians. And then the Congenital Heart Public Health Consortium provides information for physicians about how to positively impact the health of those affected by congenital heart defects. Next slide. And then finally, this is the contact information for the program here at the Ohio Department of Health. There's also a link to our website, which has recently been updated and has several resources for both families, hospitals, and providers. And I'm going to pass it to my colleague, Allison. What's that?
Okay. Good afternoon, everyone. I am going to provide you with a brief overview of the infant hearing program at the Ohio Department of Health. And we could go ahead and move on to the next slide. So the purpose of the infant hearing program is really to be Ohio's early hearing detection and intervention program, also commonly referred to as EDDI. There is an EDDI program in every state, as well as some U.S. territories. And every EDDI program adheres to or tries to adhere to the 136 JCIH recommendations. So that means that the goal is every baby to be screened by 1 month of age If that baby does not pass the hearing screening as the overall outcome, that baby then goes in for diagnostic testing that's completed by a pediatric audiologist by 3 months of age. And then if that baby is identified with permanent hearing loss, we want all those babies to be enrolled in Part C early intervention services by 6 months of age. So extremely short time frame for us to meet each of these different goals. Next slide. So how does that happen? So here in Ohio, every state is a little different. Here in Ohio, we conduct 2 screenings prior to hospital discharge. So although we have the 1 month, we like to say we do it in 1 day for the majority of our babies. Now, sometimes babies are screened a little bit later, but we are mostly concerned with the overall outcome of the screening. So a baby that has pass results, and this could be for that initial screening or the secondary screening, there's no additional testing that's needed. We do, however, encourage that hearing, speech, and communication are monitored in accordance to developmental guidelines, as well as encouraging families to make sure that they're reading and talking with their baby. We also have pass results with risk factors. So in 2019, JCIH, or the Joint Committee on Infant Hearing, they identified a whole slew of risk factors that can impact hearing. And if we have babies here in Ohio that have a pass at their newborn screening, that they have risk factors, it basically is encouraged that those babies actually get a diagnostic test by 9 months of age to provide that baseline. Then we have the overall result of non-pass results. And so if babies do have non-pass results, so this could be, again, at that secondary screening prior to hospital discharge, there's a referral that's provided for that diagnostic testing to be completed by the pediatric audiologist. And again, just referring, we want those babies to get those diagnostic testing by 3 months of age. Similar to our CCHD screening, we sometimes have babies that are discharged without the hearing screening. And that can happen for a couple of different reasons. Maybe there's an early discharge. Maybe the parents, objected to the screening overall. But then also we have a large population, it seems like it's growing, of home births. And many home births are not receiving that hearing screening as well. And so what can you do, or can you help your patients do if you have a baby that's not been screened at the hospital? So you can place a referral for a hearing screening with a pediatric audiologist if that baby is younger than 1 month of age. And obviously you can also conduct those screenings in office as well, as long as you have the appropriate equipment. If that baby is older than 1 month of age, then it's recommended that you place a referral for a diagnostic hearing evaluation with a pediatric audiologist. But if you do, in fact, provide those in-office hearing screenings, we do ask that you submit the findings to our program here at the Ohio Department of Health. So that way we can ensure the tracking and surveillance of those babies. And the fax number is listed here on the slide. We tend to get different questions here at ODH around, how do I get hearing screenings from my patients? And, if they don't pass in one ear, but they pass in the other, what does that look like? And so this is just a slide of some FAQs that we've received. So if you do have questions on, what was the outcome of the hearing screening for my patient? Ideally, the birthing hospital should be communicating those screening outcomes to all of you, as long as you are listed as the pediatrician in the mother's worksheet that's provided to the hospital. We know that that doesn't always happen. So if you are wanting those results, you can feel free to contact our program here. The phone number is listed, as well as an email address, and we would be happy to provide those to you. If your patient did not pass that first screening in one or both ears, do you have the results of the second screening similar to that first one? So again, sometimes we have babies that have a hearing screening at the birthing hospital, and then sometimes they then are transferred to a children's hospital. And maybe all of those screening results aren't necessarily combined and provided to you, but they are provided to our program here at ODH. So feel free to reach out and let us know. Some other common questions that we have is, what is a good referral source or resource for finding pediatric audiologists in Ohio? And so we do utilize and promote the national EdiPals. This website link that is here, it is available and lists the different areas of which pediatric audiologists in Ohio, as well as other states, have registered to say that they do in fact provide those services to this population. Next slide. In addition to some other resources that we have for families, we also have some resources that can be provided for both families and providers. This listed resource is our Hearing and Communication Developmental Milestones Checklist. It is specifically developed to align with how the child is progressing in terms of looking at their hearing development. And so this is available for order if that is something that you would like in your offices. And we do have it available on our website as well. And the next slide. And if you are referring babies for diagnostic testing, we also have this tips to prepare for baby's hearing test. And this is also available for your offices if you so would choose. So if you are interested in any types of these materials being mailed to you so you can have them available for your patients, please feel free to email that email and then provide the information below. These tips to prepare your babies are really helpful because a lot of times families might not know that a sleeping baby is a better way to test a baby for diagnostic testing. And sometimes those babies fall asleep on the way to the appointment. And then once they get there, they're up and they're awake, and then they have to reschedule. So we want to limit the amount of time that we are having to take out of the time, between the parents and the babies, making sure that they're ready for that diagnostic test. In addition to those resources that I mentioned, it's also really helpful if babies that are identified with hearing loss, not only do we refer those families to the Part C Early Intervention Services Program, but you can also do that as well in your offices. And it is easy as, letting the families know about Part C Early Intervention Services. An online referral can be made by this, utilizing this web link, as well as utilizing the phone number here. Hearing loss is a qualifying diagnosis for Part C early intervention enrollment. And here's the contact information for the infant hearing program. We do have a contact for screening assistance, evaluation/diagnostic assistance. And then we also have a parent consultant who is on staff who provides assistance and parent support to our parents here in Ohio. So in a similar vein, to CCHD and infant hearing, we also have different types of newborn screening support programs. The one that I'm just going to briefly mention here is our Comprehensive Genetic Services Program. Next slide. This is just a great resource that we wanted to highlight during the call today. So here in a little bit, you're going to learn more about the dry blood spot screening. And this is a wonderful resource for your follow-ups or your abnormals to go to. We do fund 8 comprehensive genetic centers throughout the state of Ohio. And these genetic centers provide the genetic evaluation, follow-up services, treatment, ongoing clinical management for some of those, for the majority of those genetic conditions. Next slide. And then similarly, we have our sickle cell services program, which also offers the support. So for any of your patients that are identified with abnormal hemoglobinopathies, those referrals can be made to the regional sickle cell program in your region. This program is, again, regionally based, and you can see the different colors for the different counties. And next to that is a listing of the contact for each regional sickle cell program. So if you are in the Cincinnati area, you have a case of a child that has been identified with potential sickle cell trait or sickle cell disease, you can make a referral to the Cincinnati Sickle Cell Center, specifically, Lisa Shook, and she'll be able to assist you. And the great part is that these regional sickle cell programs are in fact trained on how to provide that hemoglobinopathy counseling, but then they also provide that parent support that is needed to kind of help parents and encourage parents to go in for that diagnostic testing. So with that, I am going to go ahead and hand it over to Rashmi, and she'll be able to provide some information on the dried blood spot program.
Thank you. Mark, are you gonna give me the control?
So I stopped sharing, so you should be able to.
Okay. I might need some help here because I have not used Zoom a lot for sharing. Where do I go?
At the bottom of my screen, there's a green arrow that says.
Oh, yes, I see it. Sorry.
Okay.
Click on your PowerPoint and put it on one of your other screens. Now you should be able to pull it up. There it is. First one. Change that there.
Are you guys able to see the slides?
Yep, we have the slides on the screen. I think if you press like the little thing, yeah, at the bottom there, that should make it larger. There we go.
All right, thank you. My name is Rashmi Gaur, and I am the laboratory supervisor for the newborn screening dried blood spot program at the Ohio Department of Health Laboratory. And I do have my colleague Sharon with me. And I will give you a brief overview of the dried blood spot program for the state of Ohio. We have approximately 130,000 babies born in Ohio annually. And the lab receives and performs testing on more than 130,000 specimens because we do get repeats on the NICU population. Minimize that, yes. And then the follow-up team follows and does the follow-up for the abnormal results and also the inconclusives and unsatisfactory screens. So the follow-up team informs medical providers of nearly 4,000 abnormal screenings and follows the case until the diagnosis is assigned. When we get the results back from them and it helps them close the case. They also contact the medical providers with inconclusive screens and unsatisfactory screens, and they also monitor the resubmission of repeat specimens. And DBS program helps identify approximately 300 babies with metabolic, endocrine, and genetic diseases annually. So I'll talk briefly about the history of dried blood spot screening in Ohio. It started in 1966 with only one disorder that was phenylketonuria that was initially included in the DBS screening. We currently screen for 41 disorders in our panel. There is a National Advisory Committee on Heritable Disorders in Newborns and Children, also known as ACDOM. It advises the Secretary of Health and Human Services about conditions states should include on their newborn screening panel. This committee helped develop the RUSP, which is Recommended Universal Screening Panel, listing primary and secondary disorders. They also help standardize screening within the USA so that the panels are for different states are not significantly different. Ohio screens for all but one disorder recommended on the RUSP currently, and that is GAMT. And we plan to add GAMT to our panel by the end of 2025. Another fun fact that next year, July, Ohio will celebrate 6 decades of newborn screening, and that is the dried blood spot newborn screening. These are the criteria that are considered before adding conditions to the newborn screening panel, such as the disorder's incidence, mortality, and morbidity, whether the disorder causes disability, if diagnosis, treatment, and early intervention are delayed, the potential for successful treatment of the disorder, and the expected benefits to children and society in relation to the risks and costs associated with screening for the disorder. So all these factors are considered before a recommendation is made to the Director of Health for adding a particular condition to Ohio's newborn screening panel. We added Duchenne muscular dystrophy and MPS II in 2024, sorry. There are a couple of ways that the disorders get added to the Ohio newborn screening panel. One is when it gets added to the RUSP, our advisory council, and that is Newborn Advisory Council. They meet 3 times in a year, and they make a recommendation to the Director of Health. After the Director of Health approves it, it gets added to our administrative code. The other way it gets added is by legislative action. That is, a bill is introduced in legislature, and once it is approved, it is signed into the law by the Governor of Ohio. This slide shows the 41 disorders that I had mentioned that Ohio currently screens. This is a process flow. When a baby is born, the dried blood spot is collected after 24 hours of age and is transported by a dedicated courier to the lab where the testing is started. And when the results are reviewed and released for reporting, the results are reported to the medical providers. And they are the ones who, medical providers are the ones who notify the families, and they help with coordination of the follow-up activities that are recommended on the newborn screening report. And if there is a follow-up needed, then medical providers report back the diagnostic results and treatment to ODH so that the cases can be closed. This slide shows a snapshot of the NBS kit that is sent to the hospitals for collecting the specimen and recording the information that is needed for the results interpretation. This is important that the information be current, complete, and correct, and all the fields are filled so as an appropriate and correct result interpretation can be assigned. And if there is an information missing, then a timely notification of result reporting will not be possible. So when a baby is born, the results should be collected after 24 hours of age and before 48 hours. Because some analytes values fluctuate significantly in the first 24 hours of life and are uninformative. But if the baby is discharged before 24 hours, a dry blood spot screen should be collected. And per our rule, it should not be collected later than 5 days of age of the baby. However, the parents can refuse collection of newborn screening. It is birth hospital's legal responsibility to collect and ship a dried blood spot specimen for all the newborns on that, for all the newborns born in that facility. There is a religious exemption that the parents need to fill to refuse the newborn screening. Besides that, only screening for Krabbe can be refused for any reason. They do not have to provide any reason. They can refuse the Krabbe screening for their baby. In addition to that, a missed newborn screening form should be submitted to the program if the infant died prior to the screening, the specimen collection, or the infant was discharged or transferred without collection of the specimen, or if the family refuses to for the newborn screening and also refuses to sign the religious objection form. These are some of the pictures of the dried blood spot that are collected. As you see on the slide, this is a perfect specimen. The front and back are shown. Spots are uniform in size, shape, and color. I will show you in the next slide how an unsatisfactory sample might look like. In this slide, you see the front and back, and you observe that the blood is not saturated through the filter paper on the back. The blood must be evenly soaked through the filter paper for a consistent estimate of blood volume contained in the spot for accurate interpretation of the various assays. This is another example of an unsatisfactory sample. As you can see, there isn't enough blood saturated through the filter paper, and also it looks like there is some contamination issue. And these are some of the common causes of unsatisfactory newborn screen specimen collected. Baby is not hydrated enough. The heel is not warmed before a heel puncture. And then there's also an advice that for the full-term infants, puncture depth should not exceed 2 mm. For preterm or lower weight infants, puncture depth should not exceed 0.85 mm. The other cause of unsatisfactory newborn screen could be that it was collected from source other than the heel puncher, which could be an IV line, capillary tube, venous puncher, and the other cause could be specimen not properly dried prior to shipping. This slide shows the flow of once the specimen is collected. As I mentioned earlier, we have a dedicated courier, and they pick up the specimen from different birthing hospitals from around the state and deliver it to the lab. The samples that arrive at the lab after 14 days of collection are made unsat, and they cannot be tested. Once they are delivered at the lab staff separates the demographic cards from the blood spots. And then the demographic sheets are passed on to the data entry team, where these are scanned, and then data entry done on these records. And these demographic cards are stored for 2 years. The blood cards that got separated, they are visually inspected for the quality of the specimen, and an accessioning sticker is placed on these specimens, and these are punched into microtiter plates. And once we have all the punching done, these plates are moved to the instruments for testing. And once the testing is completed, the results are reviewed and released. So there could be normal results and abnormal results. When the results are abnormal or are outside of our initial trigger range, these specimens are punched in duplicate for confirming the results. And once that testing is done, an average of the retest is reported. Once the results get released, and if the results are abnormal, a case is created, and these abnormal results are called out by the follow-up team. They also do the call out for any inconclusive results, missing information, and other things. This is another flow showing how once the DBS are received at the lab, they are accessioned, punching is done, and then once the punching is done and testing completed on a specimen, these are stored for 2 years at the lab on site. And once the results are released and reported, these are electronically stored in our limbs for 21 years. And the demographic data sheets are stored for 2 years. So currently we use 8 different platforms to test for 41 disorders, and these range from the enzyme assays, immunoassays, HPLC, mass spec, and PCR. So our target turnaround time is 95% of the newborn screen specimen that are tested, get reported within 5 days. And for all the specimens with abnormal findings, results are reported within 24 hours, with the exception of Saturdays and holidays. This slide shows how the routine results reporting for the normal screening results. So the normal screening results are faxed to the birth hospitals and the PCP. At-risk results are called to the PCP within the 24 hours of results being released. The results and instructions for follow-up are faxed to the PCP. And in addition, depending on the disorder, results are faxed to the relevant specialists as well. Then responsibility of the clinical follow-up lies with the PCP. That is, the clinical lab results, diagnosis, and treatment information are reported to the newborn screening so that the cases can be closed. So in addition to the results that are being called, we do have a list of time-critical disorders. And these are some of the organic acid disorders that are time critical. And these three are for the amino acid disorder that are time critical, that are timely reporting is needed so that the recommended actions can be acted upon. This is the list of fatty acid disorders. And these are the other disorders. We just have a general category that need timely reporting. So for time critical results reporting, laboratory staff notifies follow-up team of preliminary results so that the follow-up team can ensure that the demographic information is accurate, and if need be, they can get the information of the medical provider who should be contacted once the confirmed results are released. Time critical results are called to the PCP and the relevant specialist within the 3 hours of results being released, including Saturdays and holidays. Results and instructions for the follow-up are faxed to the PCP and relevant specialist. Expectation that the clinical evaluation will be performed within 24 hours and referral to specialist will be made in a recommendation letter to the medical providers. And then again, the responsibility of clinical follow-up lies with the PCP. The expectation is that the clinical lab results, diagnosis, and treatment information are reported to the newborn program in a timely fashion so that the cases can be closed. And then I would like to end my presentation with the message that newborn screening saves babies' lives through early identification that leads to diagnosis and life-altering treatment at the earliest opportunity. Thank you for your time.
All right, and I definitely want to extend a huge thank you to all of our presenters today from the Department of Health. We have just a couple minutes left if anybody wants to unmute and ask any questions. Unfortunately, we don't have enough time to go over our data, but I'll include that in the slides. And if you have any questions about the data slides, feel free to send them to me and I can reach out back to you. Or if you have questions or follow-up from today's presentation, if we don't have enough time, I can forward those to any of our speakers today as well. Did anyone have a quick question now?
And like I said, apologies, Mark. I would share the slides as soon as I get them from my comms.
Definitely. Yeah, we totally understand that here. So, all right. If no one has any questions, I look forward to seeing everybody in April. And then another big thank you to all of our speakers today.
Thank
Have
you.
a great afternoon.
Thank you.